let's get started. So, hello all. If you are here to listen to Texas history or why Texas is better than the swamp, you are in the wrong panel. We are talking about healthcare today. And my name is Tara Aliff, and I am the policy director for the Center on Health and Families. And I have collected for you all a great panel to talk about where's the doctor and how can we get access to doctors. It'll be more than just doctors, but that's kind of the leading thing that the comms people gave me. So I'll be introducing everybody starting from left to right. So with me right now, I have the one, the only, the Honorable Tom Oliverson. Tom Oliverson serves as the Texas House Representative of District 130. He has authored legislation on a diverse set of issues, including healthcare, education, local government, religious freedoms, and the Second Amendment. God bless. During Oliverson's first session, he was chosen by his Republican colleagues as Best Freshman Legislator. His professional career, Dr. Oliverson is a board-certified anesthesiologist and partner at U.S. Anesthesia Partners. And over here, we have Genevieve Collins, Texas State Director for Americans for Prosperity. Genevieve is I already said that, I don't know why it's redundant. She focuses her efforts on empowering every American by fighting for the taxpayer at the state and federal level. Her policy activism work includes healthcare policy, turning patients into shoppers and giving them more control and choice over their care, while increasing healthcare access and reducing cost. How timely. Also, Genevieve is a seventh-generation Texan and a proud graduate of the University of Tennessee and Southern Methodist University, where she received her MBA. And over here, favorite of mine, we have the Honorable James Frank. Now he's now his sixth term in the Texas House of Representatives. Chairman Frank is also the chair of the Human Services Committee. In his capacity as chairman, Representative Frank has fought for major reforms to the Department of Family and Protective Services, working to make the department more efficient, effective, and accountable, especially on the issue of child welfare. Of particular note, he spearheaded legislation that transitioned the state's foster care system to a community-based care model and has passed several bills designed to prevent children from being unnecessarily removed from their families. Also, Representative Frank is a proud graduate of Texas A&M and holds a degree in finance.
Thank you.
There it is. It's always there. It's always there.
Always there.
And then also joining us, a new guest, new face, is Dr. Sharif Zafran, is a president of the Texas Medical Board, and he was appointed and confirmed in 2017. He is a board-certified anesthesiologist practicing in Houston, Texas. He also studied biochemistry at the University of Texas at Austin and finished medical school and residency of the University of Texas McGovern Medical School in Houston. He's the current chair of the Texas Medical Board. Isn't that fantastic? All righty, pleasantries over. So just want to kick us off. I want to hog the mic for a second and share with you some anecdotal observations I have been noting among all the healthcare policy conversations that took place last session and the interim going on now. I'm doing this so everyone here knows why I'm going to be asking our amazing panelists the questions I'm going to be asking, because healthcare can sometimes be complex and it's good to have a little bit of lead-in. So without further ado, probably the number one additive promise I heard in the legislature last year was, if Bill XY23 passes, Texans' healthcare access will drastically increase. And you could hear this additive promise in a wide range of testimonies for bills, addressing everything from questionable hospital facility fees for telehealth appointments, making healthcare prices more transparent, to Medicaid expansion, or getting taxpayer dollars to cover folks' monthly broccoli expenses. The healthcare system is indeed unnecessarily complex, but in my opinion, what Texans want out of a healthcare system is quite simple. Texans want to be able to access high-quality care and medications when they need it without having to take out a second mortgage to afford said services and drugs. Texans want access to healthcare. Due to that simple fact, you will find many healthcare policies masquerading in marketing that they will deliver on access. But you see, healthcare access, that's the key phrase and manifold kind of term I want us to focus on for this conversation. I think we all carry an implicit understanding of what determines our ability to access healthcare. The problem, though, is that if you get folks to start defining their unique understanding of access and what determines their ability to access care, not only is there a wide variance of the definition, the barriers to people's unique definitions also varies. For example, some common things I often hear is that some folks will say that speed of service matters the most, i.e., if you're at risk of dying or your condition worsens while waiting to get care or medications, that's a clear barrier to access. Tragically, case in point, ask any veteran how timely services are rendered in the VA. Some folks will say quality of service and and also the experience determines access. For instance, what's the point of going to see a doctor if you are worse off post-service? Or more likely, you find yourself in the exact same place of need and confusion prior to seeking care and trying to navigate the healthcare system. And of course, the one that's really obvious that we find ourselves talking about a lot is that people rightfully talk about healthcare prices, coverage, and out-of-pocket costs being the variables determining their ability to access care. Who wants to go to a doctor or pay for a drug? It means you can't afford rent that month. I don't like paying taxes, but I don't like paying $3,622 for MRI either, So there's no debate that we need more savvy policy and private sector innovation to improve speed of service, to improve quality of service and financing of service. These are all very important pieces of the healthcare access equation. However, there's a fourth factor that not only impacts all the other determinants I just described, I would argue we cannot have a meaningful conversation about fixing anything in our healthcare system unless we can guarantee one simple thing. Is there a flesh and blood doctor within 5 miles of your location? It's physical access, folks. It's the only time I can say this in healthcare. Simple economics. If there is not enough doctors and other health professionals for you to see, you will wait for care regardless of your need. You will get low-quality rush care, and you'll be paying for overpriced care one way or another, premiums, regressive taxes, or astronomical medical bills. To give you all an idea how bad Texas's professional shortage are, or I would say physical access barriers are, I'll give you a snapshot. 159 counties don't have a single OBGYN in the state of Texas. 71 counties don't have a single hospital or surgery center. Out of Texas' 254 counties, 248 have been designated as being a county-wide primary care shortage area. Texas ranks 41st among the 50 states in the number of active physicians per 100,000 patients, meaning for every 100,000 Texans, we only have 225 doctors. Of our total active physicians, 29% are of retirement age. Nearly 42% of all of our Texas medical students leave the state after graduating. Nearly 33% of all of medical doctors who start the residency in Texas do not finish it here, meaning they do not work here. And the kicker, the Texas Health and Human Service Commission in a 2022 report recently projected that Texas will be short 10,332 full-time equivalents. In short, it seems Texas doesn't have enough medical personnel to keep up with patient demand. We are not training enough doctors. We are not attracting enough medical personnel to come to this state. And for the people we do train, we are struggling to keep them in Texas treating Texans, especially in rural counties where we need them most. It's infuriating and it's narrowly focused, but not surprising. I was recently heckled by the New York Times and Bloomberg. They asked me, it's a great conservative honor, yes. Why hasn't Texas expanded Medicaid? Why hasn't Texas expanded Obamacare? Why hasn't Texas haphazardly conceded and spent more hard-earned taxpayer dollars on the federal failing ideas going on? It's not what they've said exactly, but that's what I heard. And, my response was quite simple. I said, what is the point of issuing more plastic insurance cards to Texans when there's nowhere to use them? Better yet, what good does an insurance card do for healthcare outcomes if Texans are still expected to drive 90 freaking miles to the nearest critical access hospital to wait in the ER? Healthcare happens between patients and health professionals, and we need to be making sure patients have agency to physically access health professionals. To quote my predecessor, David Ballot, coverage isn't access, and to quote myself, building off David, real healthcare access is determined by whether patients have the timely opportunity and freedom to pick a provider of their choice. So these amazing panelists all know this. They're all thinking about this. They're engaging with this. So let's start getting off my soapbox and asking them the real questions. So Genevieve, I want to start with you. You are doing amazing grassroots work. You are going around the state and you're dealing with Texans who are having to work through all the consequences of policy. And when it comes to this conversation about healthcare access, can you describe to me what you're seeing and what you're hearing?
Sure. So my role, I think, today is to really humanize the healthcare issue. AFP, we have offices in 14 different cities across the state. So we see every type of person that could possibly live in Texas. And we hear because we believe in bottom-up solutions and actually hearing from our constituents and communities. So I'm going to give you an example. Shirley Ryman. She lives in Jefferson, Texas. She also happens to be my stepmom. So, but she lives in a town of 1,800 people. She is in her 70s. She will kill me for saying this to y'all, but she's in her 70s, has had osteoarthritis for about 20 years, now is diagnosed with osteopenia, and has a myriad of medical issues. Now, Jefferson has not had a primary care physician for about 10 years, and she's lived in Jefferson for about 20 now. And her conditions have gotten significantly worse, but she still runs a bed and breakfast 7 days a week, every single month. She manages a 4-acre property that creates and gives plants to the community. And she's very community involved. But she's like so many people around the state that she has to drive to Longview to see her primary care physician. That's an hour away. But not only is that just her primary care physician, she has to see specialists, which are either in Dallas or Tyler. Tyler's an hour and a half away from Jefferson, and Dallas is a solid 3 hours. Now, what patients or what our citizens around the state are finding is that they're foregoing care, which is totally not okay. When you have 1,300 people moving to Texas every single day, that means that we have to start future-proofing our healthcare system. 1,300 people coming to Texas means that we're bringing in 475,000 people a year to Texas. And that many more people are going to rural areas and suburban areas, not just urban areas. And they're having real issues with access to care. They don't have doctors. They don't have primary care physicians. And when they begin punting their health care down the line because it's too far to drive, we shouldn't stand for that as a state. We should say, we need more primary care physicians. We love our specialists because they're going to cure the really acute issues that we have. But if we can get ahead of those acute issues with having more access to primary care physicians across the state, whether you're in Jefferson, Texas, or if you're in Alpine, Texas, out in West Texas, or Fort Davis, or down in the Valley, everyone deserves to have access to care with doctors that they want, because patients should be in control of their care and not the government. So we're seeing that people are actively talking about their own healthcare issues and trying to find solutions themselves. But the maze of healthcare is so complex that they begin to give up. And that's where we say, not only will AFP, Americans for Prosperity, be your patient advocate to help link you with real patient advocates, but we should have more of those folks around the state. People keep coming here and we want them, we welcome them, but we want them to live prosperous lives, to contribute well to our society, and to find personal and professional fulfillment. Part of that fulfillment is having a healthy and high quality life. And so we're looking at solutions that are going to enable that access for folks.
That's a great answer. To build off that, though, Dr. Alverson, considering you are both an active doctor and state legislator, how would you define healthcare access? And what do you feel like the state has done its utmost to address physical access barriers?
Well, let me say that I still think we have a long way to go. But I was in D.C. yesterday on a panel talking about forced organ harvesting in China, testifying for Congress, and I can tell you that the folks up there see us as national leaders when it comes to healthcare solutions that actually work. So we are making progress, and we're getting the message out there. I think when you talk about access, at the end of the day, what we really want to know is, if I'm a provider and you need care, are you able to come and see me? Am I able to see you? And are you able to afford my services? And Chairman Frank and I have had this conversation so many times, he's probably going to complete my sentence here, but the truth is that insurance itself actually makes care more expensive in most cases. Insurance itself actually limits access to care for two reasons. Because number one, you have these things called networks, and if you're not in the network, you can't actually see the patient. But also, you have cost-sharing components that have to be overcome before you can even get the insurance company to start chipping in their fair share. So one of the things that you have been working on, actually, Tanner, which I'm really excited about, is that there are all these other models that are out there. One of the things about healthcare that's incredibly frustrating to me, I know it is to Chairman Frank as well, is that healthcare, unlike almost every other sector of our economy, has been entirely resistant to that disruptive change that the gig economy has essentially brought into whatever the space is. I'm the chair of insurance. I can tell you that the insurance economy, the costs, the services, have been totally disrupted and totally reformulated and made much better by technology, by different mechanisms that are out there that can provide value. If you can actually connect a provider directly with a patient at a price that that patient can afford, that is infinitely better than giving them a plastic card and a network and saying, be well, right? Which is what we do most of the time. And the problem with our Democrat friends is that they can only think in two dimensions on this issue. For them, having a card equals care. And what we as conservatives understand, and what we understand here at TPPF, is that those two things are not the same. And so you have to look outside the box. That's one of the reasons why we've championed price transparency. And that's one of the reasons why now that we are starting to get some price transparency, we're starting to look at models like crowdsource funding for healthcare, where you actually have people that are basically participating online, just like GoFundMe, and they're contributing to each other's healthcare costs, not because they have to, but because when they need their healthcare costs paid in the future, everyone's going to get to see how much they help someone else out as a prerequisite for them getting help. So it's sort of, it's an ingenious model. I think a lot of our work over the next couple of sessions is going to be finding out ways to encourage disruptive change like that without letting the bureaucracy snuff it out. And so that's where I'm going to be focusing my time for the next couple of sessions.
That's exciting here, and we'll get into some policy here shortly. But something that's been on my mind when we're talking about access, Dr. Safran, is in places with shortages, I've been hearing a great question posed to me, because I'm coming down like with a lot of different policies and talking about all these different ways how the state can leverage bringing in physicians or other health professionals into their state safely. But I got asked a great question was, do we have a doctor shortage or do we have an efficiency shortage with doctors?
So it's a little bit of a combination of both. First of all, let me just say I'm president of the Texas Medical Board, but I am not speaking on behalf of the Texas Medical Board. So let me just kind of get that out of the way. So there's a couple of things that I would say. There is a shortage of physicians, but there's also an increased demand for care. So it's a little bit of a combination for both. There's a lot more services out there that patients need access to. There's a lot more that medicine can offer. So demand for services has gone up, as also the supply of physicians have gone down. There's a couple of things that the medical board has done, well, actually the legislature has done in passing the Interstate Medical Licensure Compact, for example, which has allowed for an easier facilitation of licensure for physicians who are out of state. So that was implemented a couple of years ago. We have since licensed about somewhere between 15 to 17,000 additional physicians. So we've gone from about 100,000 physicians who are licensed to about 115,000 physicians that are licensed. Now the problem is where it's all distributed. And we can discuss access to care in rural areas all day long, but there's a barrier that is almost insurmountable that really, when you look at the traditional way of delivering care, you're never going to be able to overcome that. Medicine has become a very highly regulated industry, even more so than it was maybe 20 years ago. The cost of being a physician and opening up an office is extremely high. And compound that with the fact that Medicare, even if you account for inflation, has actually decreased its reimbursement to physicians over the last 20 years. So you're looking at an increased cost of delivering care along with a decreased reimbursement for care. So for a physician to actually be able to open an office in a rural area where you only have a finite number of patients, and most of them may be Medicare already, if they're an older population, it becomes difficult financially to even sustain that. So one of the things that we've done as a medical board, along with increasing the number of physicians coming in, is looking at disruptive ways of how medical care can be delivered to them. Understandably, we'd like to have a physical person-to-person interaction, but it may not always be that feasible, especially when you're talking, for example, about specialty care. So one of the things that we've done, and just a quick example of that, when we talk about treatment of chronic pain, which is something that is very complex. A lot of primary care physicians who are the only physicians maybe in rural areas are afraid to actually manage that because it's complex, but they're also afraid of us as a medical board coming after their license for inappropriately prescribing, is we actually passed a rule in this last session called the GOLD plan, which is if a physician were to follow these specific metrics in delivering chronic pain management, we as a medical board will hold them harmless unless they have a specific complaint against them. And the idea behind that is that you have a physician who may be in a rural area that can interact with other providers such as psychologists and other providers or a chronic pain specialist in a manner that may be consultative, but allows for that care to be delivered in a way that that patient doesn't have to travel a long way to be able to access their medications or access the kind of care that they need. Now, of course, if they have to have an interventional procedure, they would still have to probably travel to the nearest city, but it was a way to kind of help manage that so that primary care physicians feel a little bit more comfortable delivering that care, knowing that a chronic pain physician is a phone call away, or that they can still get a psychologist or a therapist or whatever that might be, a psychiatrist if need be, to be able to help deliver that care. So the idea is, how do we think of ways to bring the patient to the physician in a way that may be not physical, but at least helps deliver that care most of the time? Broadband access, which I think was passed in the legislature several sessions ago, was part of that, because if you don't have broadband access out in a rural area, it doesn't mean anything to have a telehealth visit if you can't have that kind of connectivity. So it's a couple of things that we had to manage that way.
No, the geography is a good point in the distribution of that. But again, we have shortages, right? So if we talk about something like telehealth or getting the mobile van units, we're talking about people that have to see a lot more patients on their panel. So I guess when we have this conversation about some of the policies passed, what's looking forward? How do we bring more folks to actually come into the state with telehealth? Like, I heard of Florida and Arizona doing some very fascinating stuff with interstate, like registered telehealth. I mean, I was working on a bill over in Tennessee that recently just passed. It was a really cool thing, where essentially now Tennessee was projecting at the time to be short like 1,330 primary care docs. All of a sudden that we started talking to a lot of international physicians and kind of looking at their accreditation, who they are and what they want to do. Turns out they want to come to America. They don't like getting paid $90,000 to work in like a French healthcare system or the national healthcare system. And they do want to come here, but they just don't want to repeat a redundant American residency. And I don't mean redundant flippantly. It's just that when you have some people that are established, you're not like, these are the folks that are like, we wouldn't be leaving the country to go get a Turkish hair implant. These are like top orthopedic, Finnish doctors who are seeing like the U.S. ski team, right? And I guess what I'm curious about is, this is like catching on like wildfire, because Tennessee removed this redundant residency requirement, and all of a sudden now they're only projected to be short like 100 doctors.
Yeah, so let me kind of address that. This is a very complex issue, and I know that there was a bill that that the legislature tried to pass in the last session. There's already about, I think, 5 or 6 states that have passed something along those lines. I know the Federation of State Medical Boards, which I'm a member of the board on, has been looking at this and how to figure this out. So to put this in context, there's a finite number of GME spots out there. Physicians from overseas, or who are graduates of medical schools from out of the country, traditionally have to go through a process where they have to pass the USMLE step 1, 2, and 3. But also, in order to be licensed, they would have to go through a residency program all over again, and probably not in the specialty that they're actually experts in. So one of the things that we've struggled with is, how do we take these folks who are probably highly qualified and figure out a structure where we can make sure that we're maintaining quality, but putting them in a pathway that can help deliver care. We can incentivize certain things, like making sure that they practice for a certain number of years in a rural area, so forth and so on. There's a couple of struggles that we actually have to overcome first, and I know this is a policy issue that TPPF is looking at. The biggest struggle is, we're very good as a policy, from a policy standpoint of accrediting foreign medical schools and assuring ourselves that they have the appropriate medical school training and so forth. We don't have a mechanism yet, and this is something that we're talking about, of how to accredit or qualify foreign GME programs. So, for example, if somebody says, because part of the law, for example, in Tennessee, is that you have to be a licensed physician in another country, but you also have to have, I think it's at least 3 years of training in a GME program.
I think it's 5.
I think they have to practice for 5 years, but over there, it might be 5. But
Okay.
the point being is that I don't know how to qualify what the quality of that GME program is. There's not a structure in place to figure out if a GME program in England or in Canada or Australia, how do we figure out that that is something that we can assure ourselves that they're getting the adequate type of training and so forth and so on before we actually have them see patients over here. So there's a whole process in place, and the FSMB might be the entity that does it, the ACGME might be an entity that does it, we don't know yet. This is something that's being discussed, but we have to figure out a way to accredit those programs so that if we do bring these physicians into the workforce over here, and we say you can now go practice medicine, say in a supervised fashion for 5 years, and then potentially afterwards, like in some other states, you could have a full unrestricted license. Well, in what specialty? Because remember that when you graduate from a residency program, it's usually in a specific specialty. How do we assure that that person has the appropriate level of training? Do we require them to do a board certification? What does that board certification look like? Is it the same as what U.S. medical residents that graduate have to do, or is it something different? So there's a lot of structural things that we have to overcome, but I think that ball is rolling forward, and it's not a matter of if, but when. So it is going to be very important to figure a lot of these questions out so we can create a pathway for a lot of these highly qualified folks to do so, as well as medical students, for example, who don't necessarily match.
Yep.
So there's that component and there's that component altogether.
No. Yeah, it's definitely developing. It's been catching like in Florida and Idaho and Wisconsin, so on and so forth. And so you're seeing lots of different permutations. Yes, we are. But it's something to look forward to because we're trying to think through, I think, at least at the foundation, is like, what can the state do without needing Congress or their approval, get down to brass tacks? How do we safely get physicians or other medical personnel to trust them, like to overcome or here in practice, right? That's like the big game that's been going on for a lot of state policy just for people's context. Slightly shifting gears here over to you, Chairman Frank. I consider you someone to be a solid free market thinker, and I know you are very familiar with the consequences of having a short supply of health professionals in a district with a couple consolidated hospital systems. So I was wondering, how would you say health professional shortage affected your district and impact the state market?
That's the last part.
And the state market. Health professional shortages have impacted your district.
Well, and I've got 14 counties, and actually some of the rural counties that you're talking about, Wichita, Archer, Clay, which has pretty good population, hospital, that kind of stuff, and then 11 counties that have, in fact, I was doing one, has 265 people in the county, right? Like in almost all of those 11 counties have less than 5,000, so you're talking about that. And just you know, you have to have a combination of people in person and online. The idea that we're going to have professionals in every single place right next to somebody is, and honestly, in most cases, you don't need it as long as you have access to that professional sometimes, and then you can get them on the phone, get them online. I think is absolutely the right, you know, to have access to healthcare professionals. The lack of healthcare professionals obviously affects everybody. In the rural areas, it is the most acute, and really the continued push towards having specialists makes it even worse. You know, we have a huge number of specialists in this country, and really what most people need is general practitioners. They need to go to somebody to get care. They can go to a specialist later, but they need that access to care, and that's where, you know, Chairman Oliverson hit it. You know, in this country, we think access to care is a card. We don't care whether somebody can't afford the copay. They just need a card, you know, or if the card doesn't work. So.
No, that makes sense for me. But I feel like something that you've been noticing you talk a lot about it, is the detriment of consolidation going on.
Okay, on the consolidation side, and this is I'm going to give my quick healthcare the overview. We pay twice as much in this country for the same quality of healthcare as the rest of the first world. Twice as much. It should make everybody in here incredibly mad. If you deal with anybody in the middle income, they are getting totally hosed in what they are paying. And the reason primarily is government action in some cases, or inaction. We make it harder to get in healthcare, we make where people can't get in, and so the costs go up there. But we have the three things you need to drive down costs is transparency first. You actually need to know what something costs. If you don't know what it costs, you're never going to ask. But if you know what it costs and you only have one place to go, you're just going to know how bad you're getting ripped off, which goes back to your question. Like if you have a hospital that is a monopoly, if you have a pharmaceutical company, if you have a doctor's practice, if you have a monopoly, you can be really transparent, you are still going to badly overpay, right? I just know. Congratulations, you know exactly how bad you're getting overpaid. And the last, and that is throughout, I mean, there are monopolies virtually everywhere in my district, but even in the big cities, there are monopolies in different types of doctor practices, the pharmaceuticals. Consider this, and we did this in the state, it was pretty good. Our federal government doesn't allow importation of drugs from other countries. Okay? From Europe, we don't allow it from Canada, all for our protection, right? So you have drugs made in this country that are sold here for $500 that are sold overseas for $150. You think that's for our protection, or is it the fact that the FTC's the person there's next job is in the pharmaceutical industry? Okay? But unless we push transparent pricing, which we have pushed greatly, and by the way, virtually every hospital has fought, there's some that have done a good practice, but their organizations fight tooth and nail against telling people how much stuff costs. If you have your hospitals, go give them a call. Ask the people drinking wine and cheese, why are you wanting to hide prices from people? It's unethical. It is illegal. They're just not paying big enough fines.
You know, Genevieve, you might.
But I rant.
I love when you rant. So you make a good point. Like, we do need transparency, and I've been trying to think through a lot of different policies, but something I run into an issue in terms of access is that we can just say to a hospital, to ASC, to any really type of provider, hey, share your prices. Doesn't mean they're going to do it, especially when you have CMS drag its feet and not enforce anything, or if we have like kind of just some chokeholds here in the state. So thinking through like what can we be doing, and this is open to the entire panel, to actually equip physicians or other health professionals to care also about patients' financials.
So I think, because really the three parts, you have to have transparency, you have to have a second place to go, but you also have to have the customer who cares. Because if you have a copay, and your copay is $1,500 max out of pocket, do you care whether it's a $20,000 or a $40,000 surgery? No, you don't. So if you don't care, you're not going to shop and the price is going to continue to go up. If you have customers that have the ability to care, want to care, and have incentive to care, then the prices, you will have transparency. I think the problem is we've almost been trying to force the transparency, but you can force transparency if the customer doesn't care, it won't matter. It won't change the behavior, and it won't change the behavior of the doctor. So we need to, and there were several bills that we had trying to get that. But look, there's a ton of people that fight against healthcare costs going down. Think about how much money is out there when we are spending twice as much, it's true. I mean, you look at any stat, we're spending twice as much as Europe, Australia, I mean, anywhere. Yeah, it is. So there is a tremendous amount of money in inefficient. And by the way, it's not going to the doctors. I know we got doctors up here. It's a small percentage going to the doctors. It's going to insurance companies. It's going to the swaps with the PBMs going back and forth that are now owned by the insurance companies. And we sit and do nothing. And almost all of it is created by either government action, where we protect somebody that's already in the business, or government inaction, which is we're not taking, I'm pro-business, I am not pro-monopoly. Pro-monopolies, monopolies are bad.
Agreed. No, these are all good points, but I'm trying to think through for a second. So Genevieve, like, I don't know, you might be able to have a story too, but I remember when I was kind of bullish. I wanted to test out, like, how hard is it to shop for healthcare? How hard is it to really shop for healthcare? I happened to have a research opportunity that really put me to the test here. And I remember my senior fellow at the Sister Institute at the time was like, oh, hey, like, let's try to contrast the insurance rates for a colonoscopy and also the cash prices that providers offer. The funny thing was he didn't tell me what the CPT code was, so he just told me CPT 45378, and so I got into about like maybe 30 calls, and I realized I'm asking all these people how much it costs for a colonoscopy, so that was cool. But the thing that became really fascinating through this process was, we found some crazy stuff in like places like in Nashville where we had like an independent endoscopy center where I'd ask for I had to know all this terminology, the CPT code, I need to ask to make sure all the fees are included. It's a game to get to like an actual human being through an automated phone call. And once I did all this like hoopla, I was able to see stuff like, oh, this independent place is offering a $541 price for a colonoscopy, while less than 4 miles down the road, Vanderbilt was charging $4,628 for a colonoscopy. And while it's daunting just to see that variance, and also just by the way, the insurance companies were only like, they were negotiating colonoscopy rates down to like $3,000, or it's like, no, it's $2,600 on average, which again, the fact that there is a place that's willing to that's able to make a business doing it for $500 should make people, that's the problem in healthcare. We just don't get connected to them. And the reason I don't think we get connected to them is because, man, it was so, like, I had to like know my rights just to talk to a billing representative. So Genevieve, do you have anything like to like add like how difficult it is to be a patient shopping?
Oh my gosh, it's impossible to understand, just to even begin to understand who's in your network or who's not. You know, you have to be able to like break into Fort Knox and find the magical list of who your providers are in your network is. I think we sometimes forget we're all aware of the complexity, but there's some simple things that we forget. That as shoppers and as consumers of healthcare, it is our right, and it behooves of us to ask questions. Sometimes we forget that, oh, you're in a lab coat or you're in a doctor's coat, you know, you're an expert, you know everything, I will do what you say. That's what most people think. I mean, going into South Texas, whether you're in Brownsville or McAllen, folks just do what doctors say. And that's what we all as patients will do. But we can also ask, hey, how much does this blood test cost? And it turns out you can usually get a blood test through direct primary care for about $4. If you pay for that blood test with insurance, it's $181. That's a massive delta. But people just forget that they can ask, hey, what if I just pay with cash? You know, all of a sudden, your costs can go down by as much as 2/3. And we forget that we are empowered as patients. And one of our tenets at Americans for Prosperity, but all through this panel, we believe that we should equip patients to ask the simplest question. Hey, how much does this cost if I just pay with cash or on my credit card or with insurance? Then you have a choice, which you didn't have 30 seconds prior. And so we're trying to equip folks to ask those questions, that you are empowered. You can actually talk with your doctor and have a dialogue and not just a monologue with your physician or just take whatever the insurance is going to give you. And I think that insurance takes advantage of people. You know this far better than I, but people forget that they have choices. They can just call, to your point in Nashville, they can just call and see who all performs colonoscopies. And they have the option to see, okay, what's my insurance going to pay for? But hey, maybe I just want to pay for this. And I think one of the things that we get wrong so frequently in all aspects of consumerism is that usually the higher the price, we think the better the quality. That is not always the case. You know, you can buy, I mean, I'm sure Dr. Alverson buys $10,000 handbags, but...
Oh.
Yeah, but
strange.
you can get the same handbag for $100 that looks just like it. The quality does not always match the price. And that behooves of us to ask the questions about what, you know, if I just pay cash or pay with insurance, but does the same quality of care justify the price? Sometimes it does, sometimes it doesn't. But we deserve to be able to ask the question. And as patients, we should know that we can have a dialogue. And that's what I think so often people forget.
Prices, quality, and speed of pay. That is something that I think that's all part of the general like access equation, but I want to get back to just like a little bit centering for a second. Like, what are some other things that we have done or things that we're looking to keep doing? Because I think Dr. Oliverson, you had a pretty, and also I was going to go to you and second Chairman Frank, but Dr. Oliverson, you did something pretty interesting looking at graduated physicians. And you have a personal story behind why you wanted to do something about that. Could you describe the problem and what maybe the value add for like looking at a policy like that is?
Sure, and before I do that, let me just close the loop on what Genevieve just said, because I think she's spot on. And this is why we passed House Bill 2002 last session, which allows, if you go out and you shop around and you get a cash price that's cheaper than the network price, In the state of Texas now, the insurance company has to credit that towards your deductible. So now we're starting to build incentives, even within your plan, that would encourage you to go out and find value. Look, they're saving money, you're saving money, why would they not credit you for that? And so that's now the law in Texas, and I think it's also the law in Tennessee, right? And so we're hoping that that takes off. But going back to the graduate physician thing, you know, there are physicians every year. Well, let me just back up. So medical students in the end of their 4th year go through a applying process where they're applying to do their residency. And they have to pick a specialty that they want to go into, whether it's primary care, pediatrics, OB-GYN, family practice, or if it's something like neurosurgery, orthopedics, whatever. Anesthesia. I'm all for anesthesia. See, I have several of my anesthesia friends in here. So the deal is that you apply, and then you go interview, and then the programs that interview you rank you, and you rank them, and the computer chews it all up, and on the day that they call the match day, you get one letter, one offer only. It's kind of like the NFL draft, only it typically doesn't always work out to the benefit of the player. What ends up happening in some circumstances is that you got students who are in the top quarter of their class, but they're shooting for the stars. They're trying to get into the most competitive residency that year. Maybe it's dermatology, maybe it's neurosurgery. And you know what? They just don't quite make the cut. They get nothing. Nothing. They don't match. And so then what happens is they have to, quote, scramble into what's left over. And you think about somebody who spent the last 4 years of their life trying to get to a place. And then they wake up one morning, they open the letter, and it's like, you know, you got nothing. Go to the dean's office, see what's left over, find something that you think you might like, enjoy the rest of your life. That's how it goes. And so what happens then for those folks is that they're thrown into something that they have never thought about doing, not sure they want to do. And so a lot of them are just kind of like, well, I don't know. I can't make a decision like that. And so every year we have people that graduate with an advanced doctorate level degree, an MD, years of experience in the clinics, a body of knowledge, have already passed the first 2 steps of the licensing exam, and they are not qualified to do anything other than work at Starbucks. And so we need those folks to be augmenting our healthcare needs in this state. You know, we talk a lot about mid-level practitioners, PAs, nurse practitioners, and we need more of those folks. But what about the docs that actually have a doctorate in medicine who are sitting on the sideline working as a volunteer trying to figure out what to do with the rest of their life because they didn't match in dermatology? They're smart. They're top quarter of their class. Why can we not put them to work in the state of Texas? And so that's what Dr. Zafran was referring to earlier, and that's what we've been working on. That's a bill we filed last session, which hopefully we'll get across the finish line this time. But it's not just the foreign medical grads, it's all of these American medical grads that life just didn't quite work out for them like they wanted to. Well, let's put them to work. Let's get them paying back their loans. Let's get them seeing patients. You know what? They might actually enjoy working in primary care. Maybe they just need to try it out before they commit to it. So let's put them to work.
Waste not.
Yeah,
Waste not.
absolutely.
I totally agree with what Dr. Oliverson's saying is let people work. I think one of the things, there's a whole lot of people that benefit from shortages. And often they're in the room making decisions that keep us in those shortages.
I was just going to say real quick that
I know that's like, might as well close on that now.
I was just going to say real quick that a lot of those foreign medical grads
Yeah.
that are not U.S. medical grads are actually American students who go and, you know, they might have decided that they want to go into medicine in their 2nd or 3rd year of college. So they may not have that 3.999 GPA because they didn't go down that path to start off with. So they may go to a school in the Caribbean that is a qualified school, you know, by our own metrics. And they're also kind of caught in this quagmire coming in and trying to match. So they fall into that category also, and there's a large component out there. So it's really an untapped resource, and to Tom's credit, trying to figure out a way not only to take the U.S. medical grads, but a lot of the foreign medical grads who are actually U.S. Citizens also, and figure out a way to make sure that they are able to actually practice medicine and deliver care is important.
But every time we try to expand access, I don't care whether it's physicians dispensing drugs, push back there about somebody who doesn't want competition. If it's, nurse practitioners practicing, there's people that don't want that additional competition. Whether it's more doctors coming on, there are people that don't want that competition. At the end of the day, we don't think American people or Texans are smart enough to figure out who they want their care from. And those people are in the room telling us why we need to not do that.
I just remember last session when Americans who went and got their medical degree out of the country, they were testifying about their experience. And y'all, these folks were pleading to be able to practice. They see the devastating need that we have across the state, and they're just sitting on the sidelines. I remember this one gal, she went to London for her medical degree and can't practice, and she's like, I'm so ready. Like, put me in, coach. I am dying to help because this is what my heart, my passion is aligned to. And you're saying I can't fulfill my life's purpose. And I remember Representative Morales said, can you practice in Eagle Pass right now? And she was like, yes. And then, but we couldn't let her. And so we're leaving talent to wither, and it's not just the lack of purpose or the lack of talent, not able to do their job or what they want, but think about people who they're trying to live out their passion and truly help people and serve, and we're not giving them that opportunity. It's devastating across the entire ecosystem, and really something we can fix.
Yeah. As said, healthcare is very unnecessarily complex, and there's a lot of different people that tell you we need to go all these different directions. But I don't really want anyone walking this room, like as we start to hear more promises and more ideas and more thoughts, just keep this one thing in mind. Does whatever is being sold to you going to really improve your relationship with a health professional, and a quality relationship that delivers on your need when you need it at a price you're willing to pay? If the answer is no, you should not be entertaining it, and this is the kind of stuff you need to be asking yourselves. And again, finances will always be talked about. There will always be a conversation about coverage and other things, but start thinking through the physical access points, because that's the stuff that's really botching our healthcare system. We're not capitalizing on the state quite yet, all the untapped resources we have within the state, and also folks that we could attract to the state. And with that, I think we're going to now transition over to Q&A. And it's a foundation tradition here to remind the audience that in order to get an answer get an answer for your question, you must actually ask a question. And questions do not contain the answer within the sentence, nor are they monologues. And they're punctuated with like a question mark, which is usually reflected in a verbal upward inflection like this. So, with that, just put your hand up, and believe it or not, eventually a microphone will magically and spontaneously reach you. Oh, okay. Oh, no. Take the microphone away from that man.
And technically, Tanner's coverage isn't care.
Oh.
But
okay.
We'll bicker later.
We'll paraphrase.
But as far as the shortage of physicians, the other thing that comes to mind is, many physicians, almost 70%, are employed by hospitals, insurers, private equity. Lawyers don't have non-compete clauses, but physicians do. Is that something that can be addressed, and do you think that could help?
May I?
Of course.
Absolutely. That's the absurdity. David has hit on something huge here, and that is that part of the reason why doctors are struggling right now is because A, you can't make it on your own, and B, you're either going to end up getting gobbled up by a hospital system that basically wants to control the referral pattern. Why does the blood test cost $50? Because the hospital system can charge $50. If they can force your doctor to send all of the imaging to their imaging department, they make more money. So hospitals want to employ doctors. Insurance companies want to employ doctors. Why do insurance companies want to employ doctors? Because they make more money when care is not delivered. So ask yourself, if the doctor is employed by the hospital or they're employed by the health plan, who's actually looking out for the best interest of the patient? Now, what they do to lock these doctors in is so they come out of their training, they sign a contract, they're there, they're working, and then they have these ridiculous non-competes. Because you have hospital systems that are located in 40% of the whole state of Texas or more, they'll say you can't practice within 20 miles of any of our facilities, which means you pretty much have to move to another state, or in the case of some of the large for-profit systems, you may have a select number of states that you can go practice. So being able to trim back on these non-competes, and look, I get it. You don't want somebody taking your book of business and going across the street and competing directly against you. Okay, fine. But we've gone way overboard on the non-competes now, and doctors are literally being forced to pack up and leave, Southeast Texas and move to a whole other part of the state because they can't get out of their non-compete. That's ridiculous.
Chairman Frank, you seem fired up.
We absolutely can, and I think should make those less stringent. It's interesting what he was saying about, as an independent physician, if you refer somebody to get an imaging somewhere, you literally will go to jail if you get a kickback. But if you're an employee or hospital owned, I know they're not technically owned, but let's be real, you can have it in your agreement that you can get it, and that's why you're paying $2,500 for an image that you could get a block away for $1,000, and it's on the same machine.
So there's a couple of things I would say. First of all, non-competes are an outdated structure, and it really, if an employee doesn't want to work for you, I mean, you got to, as an employer, incentivize your employees to want to work for you, and that's how you can compete, I would say. The other thing that I would just touch on that's really important, and this is something that the medical board is supposed to be enforcing, we try to. In Texas, we have a ban on the corporate practice of medicine. Now, there's a lot of haziness in there because what hospitals will do is they'll create a 501A structure that is parallel, that has a physician board that's the actual entity that is employing the physicians. But again, realistically, they're essentially doing what the hospital wants them to do. It is very important, and same thing with private equity. There are private equity entities that are led by the corporation. There are private equity entities that are led by the physicians. Whatever the structure is, it needs to be led by the physicians. They need to be the ones making the decision. It shouldn't be a hospital saying, we haven't met our quota for how many CAT scans we've done this month. Why haven't you ordered more? It should be an independent decision. As a medical board, we try to enforce that. Again, it becomes kind of hazy when we get some kind of complaint that a physician wasn't able to do what they wanted to do because they haven't met their quota, whatever it might be. I think there's opportunities to strengthen what that looks like, to make sure that the decision-making is something done between the patient and the physician, and that relationship is between the two of them and not by the insurance carrier that now employs the most number of physicians in the country, which is really contrarian to what we want.
So one obvious answer to rural healthcare problems is expansion of telemedicine, including allowing it to go across state lines. But prior to the pandemic, the Texas Medical Association actually went to court to try to put Teladoc out of business. And so my question to you all this morning is the Texas Medical Association still standing in the way of telemedicine, or have they reversed their position?
So actually, it wasn't the Texas Medical Association, it was the Texas Medical Board. But
Oh, no.
no, well, big difference. TMA would come and they wouldn't be very happy that they're the ones that were named. So actually, just to be very specific about that instance, that was not about banning Teladoc. That was about how the structure of the relationship between a physician that is using telehealth or telemedicine and that patient was supposed to be established. It was supposed to be done by a visual interaction as opposed to just an audio interaction, and that was kind of loosened during the pandemic. We made it easier at that time. But regardless, the reason that lawsuit went away is not because the medical board was wrong. It's because the state codified what was needed to happen into law, which was in order to make sure that telehealth was done appropriately, that there needed to be an appropriate exchange of clinical information between the patient and the physician, making sure that the physician can actually visually see the patient, able to get data on that patient, are they able to actually, listen to their heart, see their ears, whatever it might be, and do so in a way that would be, number one, reimbursed appropriately, but also make sure that we're delivering care in a proper way. So it was all about the establishment of a physician-patient relationship. Where we are right now post-COVID, I think we are continuing to help open that process. I think right now the issue is a lot around reimbursement. Again, during COVID, the federal government allowed for equal reimbursement, whether a patient was seen by a physician using telehealth versus in person. And I think there's a lot of push to make sure that that continues on and is made permanent as opposed to just temporary.
If I could piggyback on that for 1 second, I think the other thing with that is that telehealth gives us an opportunity to talk about unintended consequences. And there are certain things that we don't allow here in the state of Texas, especially with the passage of Senate Bill 14, that could be facilitated by practicing medicine across state lines, and telehealth facilitates that. So there are things that I'm not saying it's a bad idea, I'm just saying that as we think about this, what we don't want is a 50-state free-for-all, because our Medical Practice Act reflects the values of our citizens, and there are certain things that we don't think are okay, like killing a child in the womb with a heartbeat, that other states have no problem with that. They'll mail order you some pills and you can kill your baby as late as you want. Our good friend Senator Donna Campbell had a really good bill on a whole other unrelated issue, which is that one of the things that we saw during COVID with telehealth is that we removed all restrictions on prescribing controlled substances online. And so you have these whole, and I'm not kidding you folks, like almost billion-dollar net worth companies, that their sole market is essentially pushing Ritalin and other medications to college kids, and all you have to do is just log on and get your face-to-face consultation with the doctor, and then comes your pills. And so this is big business now, and this was another bill that we should have passed last session but didn't get passed because of dysfunction. But very important consumer protection. We should not be letting controlled substances flow like candy across state lines. We have enough problems with illegal drugs like fentanyl. We don't need more with legal drugs like Ritalin and things like that.
I just want to just add one thing to what Tom said, because it's really important. I mean, we always look at the easy part, which is gaining access, but we've got to really be careful about unintended consequences. One of the things that we see in the medical board fairly frequently are corporations that pop up using telehealth that will push certain things. I mean, they have a patient fill a questionnaire usually not by a physician, and based on that, they will prescribe a medicine from a compound pharmacy that the telemedicine company owns, that you use that to build the insurance. That compounded cream, for example, may cost $10,000. They bill the insurance for it. Usually we get the complaint from the insurance company saying every patient that fills out this form gets this cream. Sometimes they may not even know that they filled out a form. Believe me, sometimes they don't. It's kind of done in a way that is nefarious. So we have to protect against making sure, it's important to increase access, but we got to make sure that the law is appropriately followed, and that nefarious actors are not pushing things out there that are not actually improving health or increasing health, and maybe doing things that are inappropriate.
That's good. Okay, let's go this over here up front and back. That's fine.
Hi, my name is Soren. So going off of the back of what y'all just talked about regarding telehealth, I learned about recently how there's like subscription services where you can like subscribe to a service and see a provider like a PCP. And I was just curious if y'all had heard about that. I'm sure you have. And if so, like what you think about that, and whether or not it could be good, bad. I'm just interested to get your perspective.
Well, regardless of telehealth or non-telehealth, there are direct primary care structures that are out there that I think are outstanding. When we talk about a little bit earlier about cutting the middleman out, this is one great way to do it. And whether it's using telehealth or whether it's paying a fee for a year and having unimpeded access to that one physician all year long, regardless of what's needed. And of course, if further care was needed, there might be a cost to that. But direct primary care, I think, is a great disruptive alternative model that's out there that can help increase access also.
Yeah, no, I totally agree. The direct primary care, literally you have doctors that don't have to talk to insurance companies, and they really shouldn't on the vast majority of issues that they deal with. If you're doing surgery or that kind of stuff, that's where insurance, but the direct primary care is a great model. We've done that with our employees. We've got a couple hundred employees, and the direct primary care model gets them care much better. Now, whether it's fully internet-based or I think it's better, to me, it's much better if you have some relationship. But then, honestly, the vast majority of our interactions, once you see that person and they understand, most of the interaction then is, through text and phone, that kind of stuff. So I think you can have both, but I think it's certainly the physical knowledge is good.
Yeah, but if you want any proof in the pudding,
Direct
just talk.
primary care is literally revolutionary. You can, I
Totally
mean, I
agree.
think that is something that all doctors ought to be pushing. The independent doctors ought to be pushing that because that puts doctors back in control and it puts no one in between the patient and the doctor. And I realize you're not going to get that in a lot of the specialties, but the direct primary or the general practitioners, to me, that is the primary care model or the model that ought to be pushed.
I couldn't agree more. I mean,
You could.
but I wouldn't. But I will agree with you more.
Okay.
Okay. To me, direct primary care is essentially like having a Netflix subscription. You pay a monthly fee, and you have access to your primary care physician 24 hours a day, 7 days a week, and it's a personal relationship. What we've observed kind of around the state is that many of them cap the number of patients. So you're not one of 10,000 when you go to see a doctor, you're one of 300. So there's a real personal relationship. And in Harlingen, there's a company called Frontier Direct Primary Care. And Harlingen is not exactly one of the biggest economic engines of our state. They might disagree, but I'll just say that. But they have a low median income. And in Frontier Direct Primary Care, they are able to charge $60 a month to all patients. $60 a month for your health care and a personal relationship. They have, I've talked with their chief medical officer. He says, I've got a guy who's a day worker and uses a shovel. He and his family pay $60 a month. I've also got a guy who has a private plane and more money than God, and he also pays $60 a month. It's also leveling the playing field and giving access to care at a cost that people can afford with a level of personalization. And so I think that that's one of the other things about this conversation is having a meaningful relationship with your general practitioner, your primary care physician. You want to have a long-term relationship and have these people know you so that you have continuity of care. And we see, so I'm going to completely agree with you more. We
Good
see
choice.
There it
that
is.
direct primary care is a great model.
All right, so we're just going to go down the list and praise direct primary care. But the thing I wanted to point out is that direct primary care is what is driving the secondary market for cash price services for labs, imaging, surgery, and things like that. So in addition to being a great way to get primary care at a price you can afford and actually be able to sit down with your doctor for more than 5 seconds while he's staring at the computer, not actually paying attention to you because he's busy typing out garbage that the insurance company needs, direct primary care is actually what drives the marketplace for discount MRIs and discount surgeries, discount drugs, and discount labs. So additional secondary benefits.
I completely agree with all of them. I was going to give you something more pragmatic, though. There's actually a DPC behind you. His name's Dr. Porter. So if you want to know how it actually works, he's probably texting patients now. So great man he is. Let's go for probably one of the last questions. Ooh, I like the cowboy hat. Don't worry, we got you. Got a mic coming.
Yeah, this panel mentioned the shortage in primary care doctors. So I was wondering, what can be done to incentivize medical students to pursue primary care, whereas they can make significantly more as a specialist?
I'm going to jump in, and I'm not a doctor, but I am a finance guy. That's why. They go to specialties because they make more because we pay for procedures, not wellness. We pay for procedures, so they make more for procedures. So the primary care doc can only spend 7 minutes with you on a traditional insurance model. That's one of the things I love about the direct primary care because they get paid, they don't mess with insurance, and it makes it better. I've got some specialists in my area looking at going to a direct primary care model. I've been doing this specialty, but I could go back and be a direct primary care doctor and I can actually get back to being a doctor and get paid and not have to mess with insurance. I'm not saying it's the answer to everything, but it is a major change in the financial model. You have to change the financial model before medical students are going to want to be general practitioners.
I would add to that that states have looked at this, Texas has looked at this, California has looked at this, but there definitely are models that the legislature could put into place as part of funding formulas and repayment programs, actually encouraging somebody, hey, if you go and you go to this medical school, we'll pay your whole cost of medical school, but only if you do your residency in this community that's medically underserved where you're going to do primary care. And so when you're looking at the cost of financing medical education. I mean, most doctors graduate from medical school owing more than $200,000, sometimes $500,000. And so there are things that the state could and should be doing to incentivize people to go into primary care by making it more cost effective for them on the front side. And so those are some things too.
Looks like we got one more.
My concern is the doctors themselves, because we're getting doctors that all they do is prescribe the big pharma. They get their money by prescribing all this stuff. Cholesterol, the higher your cholesterol now, the more we need, because every cell in your body has cholesterol, and the brain does too, and it needs the cholesterol. There is so much new stuff coming out that what we have been told is wrong. And I want to know, does primary care, are these doctors more knowing what's in tune? We need to educate doctors not to just give out pills, and educate them to find out what is a natural or a homeopathic way of helping these people.
Is there a question?
Yes. Is primary care
Okay.
going to help that, because they're not big pharma? You own big pharma? You don't
do
want
know
big
Eli
pharma.
Lilly.
I don't know.
I'm not a doctor, but our employees are using it. I will say, because it's a subscription based, I mean, when you go to a doctor, you literally have 7 minutes. So they almost only have time to do that. A direct primary care doc, almost every employee is like, hey, I spent more time with this doctor, and they're welders and that kind of stuff. I spent more time with this doctor than ever, because usually they're spending a lot of time up front, so they don't have to spend much time. There is a much better financial incentive for them to focus on wellness in a subscription-based model than there is in a pay-for-procedure model. So I can't speak to the medical side of it, but the financial model, I believe, is set up better for wellness than procedures.
Okay, very, very quick. So I hear what you're saying. I think you're right. We actually had legislation last session that was looking at food as medicine, because to your point, you are what you eat, and what you put in your body actually does a lot more harm or good than the pills that they give you. But this is a cultural change, and it's not just the physicians, but it's getting our whole society to understand that wellness is infinitely more important than waiting until you're sick and then taking a pill or having a surgery or whatever. It's a whole culture mind shift change. It's exercise, it's sleep, it's eating properly, it's a lot of things. So yes, I'm glad you brought that up. Thank you.
And we are at time. Please put your hands together and thank our amazing panels for joining us today. Awesome. Someone will stick around.